you go to the next step in your troubleshooting. What is the next step? You look at possible volume related causes in this patient. So hypovolemia is a very common cause of low flows in a patient once we put on ECMO. So how do you identify that? You identify that by one of these parameters. If you do have an invasive pressure monitoring, your CVP will tell you that this patient is hypovolemic, or the respiratory variations in your arterial line trace. They may not be very prominent because you have come down on your ventilator settings in these patients already. So a monitoring of your invasive pressures will tell you, or if you have an echocardiography, you put in echocardiography, the way your heart looks like, both the chambers being empty here with kissing papillary muscles, or the way your IVC looks like, it being totally collapsed and having movement with inspiration. Any of these will clinch you that this particular patient is possibly hypovolemic. So what do we need to think and what do we need to look beyond this? First, it may happen that if you have instituted an ECMO a little while ago, the patient initial flows may be stable, but down the line he can have a low flows because of hypovolemia. That can be multiple reasons. One, you had some blood loss at the time of ECMO initiation, which you have not adequately replaced and probably now needs more volume. Initial flows may be maintained, which you see that maybe because of multiple reasons, but once they settle down, that's when they start manifesting that hypovolemia and low flows. That's one. Second, you have anticoagulated this patient. There can be an ongoing bleed in your cannulation sites or elsewhere. So you do a quick check whether there is any bleeding anywhere which is resulting the hypovolemia, and if nothing is there, if it is just a pure hypovolemia for different reasons, which may be there even before you put a patient on ECMO, you just go ahead and treat it. Okay. Along with that, if this particular patient is on ECMO, let me say for some time, is on ECMO for a week days or 10 days, then you start seeing this particular trouble of having low flows, and you identify the reason for the low flows is hypovolemia based on one of these parameters. You need to think a little beyond this. Why is this patient hypovolemic? Of course, giving volume will solve your problem. You can get back to your ECMO flows and get back the saturation to normal, but you need to think why this particular patient is hypovolemic. This can be one of those losses. One is for some reason or other, if you are diuresing this patient and this patient over days has become cumulatively negative balance, totally dried out, fine, that explains, that's well and good. Along with that, other possible complications that can happen ECMO is a blood loss. Like you can have a blood loss in the gastrointestinal tract like stomach or intestine, or you can blood loss in the cannulation sites, or you can have blood loss in the retroperitoneal areas. What is the speciality about all these blood losses? The gastrointestinal cannulation sites, that is into the compartment, or in the retroperitoneal, can be large volume blood losses. In the sense you can lose 500 ml or 1 liter without any overt manifestations. In the sense you don't see that the bleeding there. Your Ryle's tube may not be sucking anything. Your cannula site may not get soaked. In retroperitoneal you don't know or you don't see anything. In the initial blood gases, you may not see a fall in hemoglobin also, which is a large or a significant number. What is the first sign that tells you is a relative hypovolemia, which may manifest as a low ECMO flows. So you start thinking, you start looking for reasons, you start thinking, is this patient having an ongoing blood loss? If he's having an ongoing blood loss, yes, you do temporarily replace the volume, you settle the flows, but along with that, you also look for other ways to handle this primary problem, that is a blood loss. Okay. Similarly, another scenario where you can see this hypovolemia is third spacing. When do you see third spacing? Usually you see as a sign of sepsis. If your patient is not clinically having overt sepsis, which can happen like if you have a hypotension or a frank fever episodes, it can also happen that you can just be having signs like it's the slow third spacing, which can be missed, like other sepsis in that particular patient may be missed, or the bug may be a resistant one and the antibiotic you are giving may not be the one that is adequately covering. In that situation, you do see this third spacing. The patients will have paralytic ileus or edema there, which will lead to a relative hypovolemia that can lead to a flow fluctuation. So, if you have a flow fluctuations on a patient on ECMO and You do screen it. You identify that this patient has hypovolemia based on your invasive pressure, echo or IVC, one of this. So once you identify that, yes, you go ahead and treat it with volume, but simultaneously you also look for what really caused this. Is there an ongoing blood loss which you have missed or which is not yet manifested? Like if it's a GI, they need to have an RT aspirate or melena, which can take some time. Or is it an ongoing sepsis? So you think on these lines, you think a little beyond and try to handle a complication at the earliest.